Yes, I hope there's no problem like last time. Uh, okay, today I will continue my topic on surgical sterilizations. Last week I told you about the vasectomy, no scalpel vasectomy, and also the various methods of tubectomy, how to do, what is the technique, the names of the techniques, etc. I will continue with this topic. Today I will talk about complications of tubectomy. uh, what are the various complications? Since it is a surgery, like any other surgery, some complications will be there, which can be overcome. Anesthetic complications, because we give anesthesia, regional anesthesia, or a short general anesthesia, or sometimes in mass camps, only local anesthesia is given with some IV sedation. Uh, so, with all these drugs and the methods, some complications may be there, like say a spinal block or failure of the spinal, or a cardiac arrest, or uh, idiosyncrasy to the anesthetic agent and some convulsions, etc. And then, apart from the anesthetic complications, what are the complications due to the surgery itself? Mortality is about 4 per 1 lakh procedures, and most of the time, the reason for the deaths is either hemorrhage or infection or embolism. Now, morbidity is also mostly due to infections, where because of the wound infection, infection of the tubectomy site or the infection of the abdominal incision, there may be wound infection, there may be peritonitis, there may be PID, that is general tract infection, or sometimes with the peritonitis, it may progress further, bowel infections or paralytic ileus, etc. Then, postoperative lung infection also is a possibility, particularly if general anesthesia is given. Then, problems with the surgery itself, there may be trauma to the bladder and bowel. Bladder, if care is not taken to empty the bladder, that's why any abdominal surgery, particularly any gynecological surgery, the woman must empty the bladder before we start the surgery. If she has not emptied the bladder, you have to catheterize the bladder and see that it is empty. You know, a full bladder extends, becomes filled with urine, and extends almost up to the level of the umbilicus. So, if you take a lower abdominal incision, then if you don't recognize the bladder, then you may be incising the bladder and injuring it. So, always an empty bladder is very important. Then, bowel trauma, particularly if the woman has had previous infections or previous surgery, intra-abdominal adhesions may be there. And suppose the bowel becomes adherent to the anterior abdominal wall, and when you are incising the abdominal wall and separating all the layers, you may incise the bowel or the omentum. So these are the complications. Then post-op complication, like any other post-op patient, a thrombophlebitis, particularly if they have a tendency for this thrombophlebitis, that is DVT, deep vein thrombosis in the lower limbs, where because of the stasis, because of surgically, because the patient is lying down, she's not walking about, stasis of blood will be there in the lower limb veins, and then thrombosis will occur. Now, this thrombosis, then the thrombus can get dislodged and go to the in the bloodstream to the different organs like lungs, kidneys, brain, uh, and cause embolism. So, pulmonary embolism, cerebral embolism, all these can occur as a complication of this thrombophlebitis, which leads to lot of morbidity and mortality. Then later, because of adhesions, because of infections, pelvic adhesions can form, which may affect her future for, uh, like she may develop any other complications. Then failure may occur, and if it fails and a spontaneous reconvalescence has occurred, then patient will become pregnant. The ectopic pregnancy can occur. This may be because though you have done the disruption in the fallopian tube, sometimes it may join back. A partial reconvalescence can occur. So, a fallopian tube becomes patent but not completely patent. So it allows the passage of a sperms or the ovum, but then the fertilized ovum, as it is increasing in size, as the cells are dividing and it is increasing in size, it gets obstructed at the site of the surgery, and so an ectopic pregnancy can result with its own complications like rupture of the ectopic hemoperitoneum, patient going into shock. Then DUB, that is abnormal uterine bleeding can occur, menorrhagia can occur following a tubectomy. It has been seen in some cases. The exact reason we are not able to say, but probably it is because of the disturbance in the blood supply to the fallopian tube and to the uterus. You know, the at the level of the cornu, there is intermingling of blood vessels, of ovarian vessels, branches, and the uterine artery branches, and then all this blood supply is disrupted, so there is more congestion in the uterus, and because of the congestion patient bleeds more during periods, that is menorrhagia occurs. But usually that's a response to simple non-hormonal treatment. For a few months she may have, and then it settles. Then, occasionally, a depression and regret that she has undergone her tubectomy and she's lost her childbearing function. You see, people do react differently. The thinking will be different, and she may have taken the decision for a tubectomy because of family pressure. Then later she will regret, or she may lose a child and then she regrets why she has got it done and go into depression. Okay, these are not common, but it can occur. So these are the various complications that can occur in these cases. Yes. Now let us go to the laparoscopic sterilization. Now, what is laparoscopic sterilization? By using an instrument called a laparoscope. You all have heard about laparoscope. You know what is a laparoscope? It is a fiber optic instrument. We have got a rigid scope, which a scope is an instrument which visualizes, which sees. That is a scope. Then it is called a laparoscope or hysteroscope, etc., depending on where it is used and what it is seeing. Laparo means inside the abdominal cavity. So an instrument which sees inside the abdominal cavity is a laparoscope. We have got hysteroscope. Hystero means uterus. So an instrument which sees the inside of the uterus is called a hysteroscope. Like that, you have got a cystoscope. Cystoscope sees the inside of the bladder. You have got a fetoscope. Fetoscope sees, which we pass into the amniotic cavity to see the fetus. So fetoscope, like that. So different scopes are there. And now utilizing this laparoscope, we visualize the fallopian tubes and put a ring on the fallopian tube. That is laparoscopic sterilization. This we call it a double puncture laparoscopic sterilization. Why we call it a double puncture? Because we are puncturing the abdominal wall. That is, we are making a tiny small incision in the anterior abdominal wall in two places, double puncture. So through one puncture, which we do subumbilically, we pass the scope itself, that laparoscope itself. Then through another puncture, which is done midway between the umbilicus and the pubic symphysis, there that through that we pass the actual instrument which applies the rings on the fallopian tube. So this is a double puncture laparoscopic sterilization, DPL. Now this is used for mass sterilization in large camps. It is very useful for camps because it can be done very fast. Simply, there's no need to cut open the abdomen, take out the fallopian tube, ligate it, and then put it back, and then again suture the abdominal wall. All this time is not spent. So it is just a puncture is made, two punctures are made, two instruments are passed, rings are applied, instruments are taken out, the CO2 gas is let out, and when in the camps, there is no need to even suture the incision in the abdominal wall because the incision is less than half centimeter. It's just about half centimeter. So which you just bring the edges together and apply a plaster. That's all. So it is a very fast method also. Experienced laparoscopic surgeons can do even up to 1,000 cases per day. That is, say some years back when mass camps were conducted and people were getting motivated and we were doing, some of us could do even about 800 to 1,000 cases per day. So that you can imagine how fast it has been done. Okay, so this can be done. This DPL can be done under local anesthesia or general anesthesia. Naturally, in the camps we do under local anesthesia. In hospital setup, then we may do under general anesthesia. Now, this is, as I told you, this is very suitable for mass camps, and it is useful for interval sterilization only. Now, previously in my previous class, I told you what is interval sterilization. When we do the sterilization, when in between pregnancies, interval we call it because it is in between pregnancies. Like, see, when the patient is not pregnant, we are doing this in the proliferative phase, in the first half of the menstrual cycle, in the pre-ovulatory phase, we are doing it when the patient is not pregnant. Or sometimes we can do it when the patient is pregnant, but we are also doing a termination of pregnancy. MTP we are doing, but then that is in the earlier weeks only. Now, in the postpartum period, we cannot use this method. Why? Why we cannot use this method in the postpartum period? Because in the postpartum period, for one reason, the uterus is large. See, I told you when I was talking about postpartum tubectomy, immediately after delivery, the height of the fundus is approximately at the level of the umbilicus, and it reduces by approximately 1 centimeter per day in the next 1 week. And after 1 week, it becomes an pelvic organ. Now, so if we want to do in this 1 week, then what happens? The uterus is large, and when you're putting the either the laparoscope or the ring applicator into the abdomen, then if you use a lot of force or if you're not careful, you can easily injure the uterus. A uterus which is at the level of the umbilicus or slightly below that, and you are making your incision to put the laparoscope at the level just below the umbilicus, then with the trocar and cannula, you can simply injure the uterus and profuse bleeding can occur. And remember, still in the postpartum period, uterus is soft and it is highly vascular. Lot of blood vessels are there. So profuse bleeding can occur, hemoperitoneum can occur. It is a dangerous situation. That's one thing. Injury to the uterus can occur. Now, another thing is in the postpartum period, as the uterus is enlarged, simply similarly the fallopian tubes are also edematous and thickened. They are not like in the non-pregnant situation. They are thickened and edematous. So if we try to apply rings to these fallopian tube, so in this postpartum period, picking up the loop and applying rings, the ring will not fit onto the fallopian tube because of the edema, and then it can only compress it partly. Recanalization occur. Okay, not only that, it can injure the fallopian tube because it is not fitting tightly on the fallopian tube. It is only partially fitting. Injury to the blood vessels can occur, and again bleeding can occur. Failure of the method can occur. So, because of all these reasons, laparoscopic sterilization cannot be used in the postpartum period. But as an interval sterilization, it is one of the best methods. Yes. So how do we do it? A small subumbilical incision we make with a sharp scalpel, and then this is deepened, and an instrument called a Verri's needle. It's a very narrow one, 2 mm diameter, and the tip is rounded so that when it enters into the peritoneal cavity, it does not injure the bowel and the omentum. So this is inserted through this incision, and then through this Verri's needle, CO2 is passed into the abdominal cavity. We want to create a pneumoperitoneum. Pneumoperitoneum is air in the or gas in the peritoneal cavity. Now, why we use CO2 and not any other gas or not even air is because CO2 is very easily absorbable in the body, and then it is very least harmful to the body. Okay, so we introduce a certain amount of CO2 at a certain pressure. Now, so that the abdomen gets distended, the peritoneal cavity gets distended. Now, why should we create this pneumoperitoneum? So that all the other organs, particularly the bowel and the momentum, are pushed away from your field of surgery, and you can visualize the organs clearly. You can visualize the uterus, fallopian tubes, and ovaries very clearly. Pick up the fallopian tube and apply the rings. So, for that, we create this pneumoperitoneum. Yes, then after creating the pneumoperitoneum, the Verri's needle is removed, and then through the same incision, we introduce a trocar and cannula. A trocar and cannula, it's like any other trocar and cannula which is which are used for many other procedures, paracentesis or for pleural effusions, etc., where an outer cannula is there, inside trocar is there. Now the inside trocar has a sharp end which punctures the tissues. So this trocar and cannula, which is quite thin, is only 5 diameter, is introduced to the same incision. And then once the trocar and cannula is inside the peritoneal cavity, the trocar is removed, cannula is left behind. Now through this cannula, then we introduce the laparoscope. Then once we introduce the laparoscope and see the various organs, then we make sure that there are no adhesions, everything is clear, everything is fine. Then we make another small incision, that is double puncture, I told you. So another small incision midway between the first trocar and cannula, and what we call it a portal. Entry point is a portal, okay? First portal, and we make another portal, okay? So another trocar and cannula is used to make another puncture. And then again the trocar is removed, cannula is left behind. And through the second cannula, we introduce the ring applicator. Now, this ring applicator is like a long forceps only. So with the ring applicator, then the fallopian tube is picked up. We visualize all the organs, pick up the fallopian tube near the isthmus, and then when the top of this ring applicator is pressed, this ring is made of silastic material, inert material which does not cause any inflammation, any damage, any harm to the patient. This silastic ring is then applied onto the loop of the fallopian tube. Then this is repeated on the other side also. So after applying rings to both the fallopian tubes, then the ring applicator is removed, and the cannula is removed, and then the scope is removed, that is laparoscope is removed. The CO2 gas that we have introduced in the peritoneal cavity is then let out through this cannula, and then after all the gas is let out, the cannula is also removed. And when this suturing the incision is also not necessary, just putting a plaster, bringing the edges together, that's enough. Now, sometimes people have used cauterization also. Bipolar cautery has been used to cauterize the fallopian tube. Instead of applying the rings, initially bipolar cautery was used to simply burn the part of the fallopian tube. Now, what happens here? This disrupts the fallopian tube, no doubt, and it's a very good method, no doubt. But then this causes more damage. More length of the fallopian tube will be lost, and if this patient comes back for recanalization, it is difficult to do the recanalization. So now what we are doing is the applying the rings in the ring applicator. Yes. Then the failure rate is approximately 0.6 per 100 women years. The failure rate is so low, you can imagine, only 0.6. That means 6 per 1,000 women years. Now, various materials, clips, etc., have been used to apply to the ring. You got the silastic fallope ring or hulka clip, which is like a clip, filshy clip. All these have been used. In other countries, this hulka clip and filshy clip are used, but in our country, we are using silastic fallope ring, it is called. Now, this fallope ring is like a band. The outer and inner diameters are 3.6 and 1 and the thickness of the ring is 2.2 And this ring is impregnated with barium sulfate so that this can be visualized if a radiograph is taken. Suppose you want to know whether the fallope ring is in place or not, or it's got displaced somewhere, or you even want to know whether the rings have been applied or not. You can simply take an X-ray and make sure. See, this picture shows the how it is done. You can see this is the laparoscope. This is a long instrument. This is the eyepiece through which we visualize the fallopian tubes. If we can connect a camera to this eyepiece, we can visualize this on a TV monitor also. Yes. And then you can see that black space is where has the mouse gone? Yes. This is all the pneumoperitoneum. Okay. This is the uterus, this is the ovary, this is the fallopian tube. You can see this is the light falling on the fallopian tube, and then we see this fallopian tube. This is the second portal or second cannula through which the ring applicator is passed. Then this loop of the fallopian tube is picked up and the rings are applied to the fallopian tube. See, the patient is placed in the lithotomy position with the thighs flexed. Now, because pneumoperitoneum is created, all the bowels and the omentum have fallen away. We also elevate the uh, buttocks or lower the head end so that the bowels fall backwards. Now, this is the actual picture how you visualize through the laparoscope the organs. You can see this is the uterus. This whole thing is a uterus. This is just an instrument pushing the uterus forwards. This is the origin of the fallopian tube. You can see this is the fallopian tube. This is the loop of the fallopian tube that has been picked up. And then you can see two rings having been applied to this fallopian tube. These white ones are the fallope rings. We apply two rings on each side to each fallopian tube. This is the fimbral end of the fallopian tube. This is just a bowel. This is omentum. You can see the yellow one. And this white one behind is the ovary. So this is the left fallopian tube and the left sterilization. This picture you can see both the fallopian tubes have been ligated. This is the right side fallopian tube with two. This is the loop of the fallopian tube. Because we applied the rings, it has become whitish. See, blood supply has stopped, so it has become whitish. This is the femoral end of this tube. Then this is the uterus. Now, this is the other origin of the other fallopian tube. This is the loop of the fallopian tube, which has become whitish. These are the two rings on the tube. This is the femoral end. This is the ovary, left ovary. So, when you visualize after applying the rings, this is how you will see the uterus and both the tubes. After a few days, what happens is these ends will separate. This loop of the fallopian tubes gets necrosed and it falls off, and these ends of the fallopian tube actually separate with the rings on either this side or that side. Yes, so what are the advantages of this laparoscopic sterilization? It is a small subumbilical scar. When it heals, it's almost invisible. So cosmetically also it is very acceptable. It can be done under local anesthesia, and because of simple procedure, patient can be discharged on the same day. No need for prolonged hospitalization of the patient. Very useful for large sterilization camps. And reversibility is very high, more than 70% success rate if you do surgery for recanalization. For some reason, the patient comes back saying, "You change it again, I want to have another big child." She has lost the previous children or something happens, she wants another child. So, again, doing a surgery and bringing the ends together and doing a tuboplasty recanalization procedure is much simpler, much easier, and more successful following a laparoscopic sterilization rather than a conventional sterilization. So 70% success rate is there. But what are the disadvantages? That is the expensive equipment. This equipment costs some lakhs. So, and then training is necessary to do this procedure. Every person cannot do this. Trained person. See, that is why these gynecologists, we send them for a training to hospitals, major hospitals like government hospitals, like government maternity hospital, Petla Bazar, Sultan Bazar Hospital, or Nilafar Hospital, Gandhi Hospital, etc., where all people come from the districts, all the government doctors, gynecologists, and get trained. They go back and then conduct the mass camps. So remember, most of these camps are conducted by the government. These mass sterilization camps. Of course, sterilizations are done even in the private sector. Even we do in our hospital. We do this laparoscopic sterilization. Okay, what are the complications? Like any other procedure, some complications can occur. there can be surgical emphysema in abdominal wall. This happens, see, I told you we introduce a Verres needle into the abdominal cavity and then introduce the CO2 gas. Now, if the tip of the Verres needle is not in the peritoneal cavity, it is in between the layers of the anterior abdominal wall and you have missed it, and then we have introduced the air, then what happens is this CO2 will collect in the between the layers of the abdominal wall, and so this abdominal wall swelling will occur, what we call a surgical emphysema. Now this collection of the gas, you can actually, when you palpate the abdominal wall, you can see the crepitus. I hope you all know, you have been taught in surgery what is a crepitus, isn't it? It makes a crackling sound, and that feel is also there because the gas has collected in the layers of the abdominal wall. Now, sometimes this can occur inadvertently, but it is not dangerous. It is a little rest and usually it subsides. Only problem will come if this extends upwards into the neck. If a large surgical emphysema is there and it extends into the neck, it can compress the vessels in the neck. But then then we make multiple incisions in the skin to let out this gas. Usually it's not a major complication. Then bleeding from the superior epigastric vessel can occur. You know the superior epigastric vessel runs in the anterior abdominal wall just beneath the rectus sheath, isn't it? So when you are puncturing with the trocar and cannula, if your site, if the site you have chosen for the puncture is goes a little laterally, then you may be injuring this epigastric vessel and bleeding. A hematoma can form in the anterior abdominal wall. Sometimes a huge hematoma also can form and patient can go into shock. Then injury to the fallopian tube, to the mesosalpinx, particularly if there is some adhesion close by or if the tube is thicker than normal, it's highly vascular, then bleeding can occur and hemoperitoneum can occur. Uterine perforation, I told you, if the uterus is large, if you are doing the MTP, termination of pregnancy, for a little more advanced pregnancy, and then uterus is large and soft, it can get injured. A wrong application of the ring. You may apply that, you may not see that it is a fallopian tube. See, always you recognize the fallopian tube. How do you recognize? You always see the femoral end of the tube and recognize it. Make sure it is fallopian tube by seeing the femoral end, because femoral end is not present on round ligament or ovarian ligament. It is present only on the fallopian tube. So if you don't, if you are not careful, or if because of visualize the fallopian tubes properly, and you may have applied the ring to the round ligament or to the ovarian ligament, then naturally failure of the procedure because the correct tube has not been blocked. Then spontaneous recanalization, sometimes the edges can come together, and then failure of the procedure and patient can become pregnant. Ectopic pregnancy, I told you, a partial recanalization and the fertilized ovum will get stuck at this site and ectopic pregnancy will occur. Hydrosalpinx can occur. See, I have shown you the procedure where two rings are applied on the fallopian tube. You have seen that very close to each other, isn't it? But suppose you apply these tubes a little far apart, say 2 centimeters apart, then what happens is the tubes are occluded, no doubt, but the in between these rings, for some time, the mucous membrane of the salpinx produces mucus, isn't it? This mucus will collect in the fallopian tube and a hydrosalpinx will occur, and it may increase in size and create problems for the patient. So those are a few complications. So what are the contraindications? Which patient you will avoid or you will be very cautious? If the patient has a cardiac or a pulmonary disease, because see, you're filling the gas into the peritoneal cavity, the diaphragm also gets elevated. When the diaphragm gets elevated, it puts a pressure on the chest, on the thoracic cavity, and so the lungs and the heart are pushed out, and then they may be compromised. So if the patient has a pulmonary disease or a cardiac disease, it creates a compromisation of these organs, and then patient's condition may become worse. So we avoid in such patients. Yes, then previous extensive abdominal surgeries, and you may have see adhesions or you may cause intestinal injuries. So because of that, you may avoid us. this procedure. Then a puerperal patient, I told you the reasons why we do not do. Then extreme obesity, where the patient is very obese, the anterior abdominal wall is very thick. Even the your Verris needle that you are putting, even if you take the longest needle available, still the tip of the needle may not go into the peritoneal cavity. It may remain in the abdominal wall itself and cause surgical emphysema. So in these patients, it's difficult to do uh, 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 laparoscopic surgery. So it also depends upon the, of course, on the skill of the surgeon also, but it causes problems. Yes. Then if there is an umbilical hernia or a diaphragmatic hernia, see umbilical hernia, the bowel may be present in the hernia and you may be injuring the hernia, isn't it? Because your first portal you are taking just below the umbilicus. Then diaphragmatic hernia, when you are filling the peritoneal cavity with air, this diaphragmatic hernia, the hernia may be pushed more into the chest cavity and it may increase in size and the condition worsens. Then PID, if the patient has history of PID, then both the fallopian tubes may become adherent, they may become thick, they may not be visible also, and you cannot easily separate them to pick up a loop of the fallopian tube and apply a ring. So your procedure may fail. So she is not an ideal patient. So that is about the laparoscopic sterilization. Now a few words about the hysteroscopic sterilization. Here, how can we do a hysteroscopic sterilization? Hysteroscopy is where we are seeing the inside of the uterine cavity, isn't it? We cannot see the fallopian tubes through the uterine cavity, isn't it? But what we can see are the openings of the fallopian tubes into the uterine cavity, what we call the tubal ostium. So hysteroscopic sterilization we can do by seeing the tubal ostia and then blocking the tubal ostium so that the sperms do not enter into the fallopian tubes and the ovum cannot reach the uterine cavity. So what have been used were sclerosing agents and quinacrine. Just it is placed in the tubal ostia, and causes inflammation and blockage of the fallopian tube. Now, but with these sclerosing agents, extensive length of the fallopian tube will get blocked, inflamed, and then later patient you cannot do a recanalization, and not only that, additions to the surrounding structures, etc., more rupture of the fallopian tube, more complications. So we are not doing it now. This another method, Assure, has been tried and it is being used in other countries, though it has not been taken up in our country. Assure is nothing but it's a small device. It's a micro insert, a very tiny one, which we insert into the fallopian tube, visualizing the tubal ostium through the hysteroscope. Now, it consists of an inner stainless steel tube coil, a very fine stainless steel coil, and also there's an outer coil which is coated with a terephthalate fiber. Now, this is introduced through the ostium into the proximal part of the fallopian tube. It causes local tissue reaction, inflammation, and so tubal block. And it takes 3 months for this device to be effective. And so, in these 3 months, another method of contraception has to be utilized. Now, what are the disadvantages of hysteroscopic sterilization? Again, a hysteroscope is necessary, that is, equipment is necessary. Then, training of the surgeon is necessary. Another complication is perforation of the tube can occur, or the device may be expelled into the uterine cavity, or it may be expelled through the femoral end into the peritoneal cavity. Then, also, it takes 3 months for permanent occlusion of the fallopian tubes. So it is not the ideal method. So this completes my series of lectures on contraception. Today, since more time is there, I'll take another small topic. Please stay. Right, thank you. So today I will talk about another topic, small topic it is, don't worry. I won't detain you for a long time. Compound presentation. Now compound presentation. What is a presentation? Presentation is the part of the fetus which presents over the brim of the pelvis. We call it a cephalic presentation when the head of the fetus is presenting over the brim of the pelvis, because the fetus has to come out through the pelvis, isn't it? Through the pelvis, through the vagina, and outside in the introitus, isn't it? So, and when the buttocks of the fetus, or the feet, or the knee of the fetus is presenting, then we call it a breech presentation. Now, in a transverse lie, it is the shoulder that is presenting over the maternal pelvic inlet. Then we call it a shoulder presentation. Now, what is this compound presentation then? Compound presentation is when it is a longitudinal lie only. It may be a cephalic presentation or a breech presentation, but along with the head or with the breech, then a hand or a foot also comes out. It's trying to come out. It is present when with the cervix dilated. You feel along with the head either a hand or foot, or along with the breech a hand or foot is felt. Both are trying to enter the pelvis at the same time. You see this earlier part of the labor, in the first stage of labor, and sometimes a cord also prolapses along with this. See, all this can happen. Why? Because there is more gap in the pelvis, in the brim, at the brim of the pelvis. It is There is more gap. Why? Because the presenting part is not fitting well into the pelvis. If the presenting part is not fitting well and a gap is there, naturally cord can come out, or the hand can come out, or the foot can come out, isn't it? So, in all the conditions where the fetal presenting part is not fitting well into the cervix, into the brim, then we see this condition. So, the incidence is not very high. Uh, See, this is how it is presenting. You can see this brim of the pelvis, and see, this is the pelvis. This is the brim of the pelvis. This is the vagina. This is the cervix. See, end of the cervix. Cervix is partly dilated, you can see. This is the uterus with the fetus. Now, this is the fetal head that is coming out. Normally, only the head should try to come out. Now, here the hand is also trying to come out. See, when you do a pelvic examination through this dilated cervix, what you will feel? You will feel the scalp of the fetus, and you also feel the fingers of the fetus, fingers of the hand. So, this we call a compound presentation. Now, the incidence is about 1 in 500 or 1 in 1000 deliveries. What are the causes? I told you, wherever the presenting part is not fitting well, this can occur. In prematurity, where the fetus is small, fetal head is small, the pelvis is normal size, it is large, the brim of the pelvis is larger than the size of the fetal head. So there is more gap, and so along with the fetal head, the head or hand tries to the hand or the foot tries to come out, or wherever there is premature rupture of the membranes. Even before full dilatation, the membranes have ruptured, cervix is partially dilated, presenting part has not descended much, so there is a gap, and so the hand or foot comes out. In a multiparous woman, the abdominal wall is lax, the tone is less. Even the uterus is lax, uterine tone is also less. So what happens? The fetus, the uterus and the abdominal wall are not putting a much pressure on the fetus, on the body of the fetus or on the head of the fetus, and so the fetal head is not fitting into the into the pelvis. So it is still high up, and so there is a gap, and then the other parts can come out. In polyhydramnios, there is excessive liquor in the amniotic cavity. Now, when this liquor is excessive, the fetal fixation into the pelvis does not occur. Fetus is nicely swimming in the amniotic fluid. So much fluid is there, fetus will not try to come down. It is swimming, and so any malpresentation can occur. Even if it's a cephalic presentation or a breech presentation, the presenting part will not fit well, and so anything else can prolapse. Then, in multiple pregnancy, in multiple pregnancy, there more than one fetus is there. So, in when two fetuses or more are present, both of them will not be present in the cephalic presentation or breech presentation always, isn't it? So they try to just adjust towards each other. So malpresentations will be there. So gaps will be there. Then in contracted pelvis, in a very severely contracted pelvis where the brim of the pelvis is very narrow, the head is not able to fit into the brim of the pelvis. It is higher up above the brim of the pelvis. So when the cervix is dilated, membranes have ruptured. There are gaps. Head cannot come down completely, and so through the small gap, either the foot or the hand will come out. Yes. Now, what are the types? Basically, it may be a cephalic presentation or a breech presentation. So, cephalic presentation with a prolapse of hand, one hand or both hand, or a foot, one foot or both foot, or hand and foot together along with the head. See, all this can come out along with the head. Then, or a breech presentation with a hand prolapse. Now, most common is the head and hand is the most common one that we see. How to diagnose? It is simply during labor when the cervix is partially dilated and the membranes have ruptured. You do a per vaginum examination. You see that the head and you will feel actually you will feel the head and the hand together at the same time. Now, how do you manage? Most important is you exclude any cord prolapse. If membranes have just then ruptured and you've done the pelvic examination and you feel the cord and the prolapse has occurred and the cord pulsations are still present, then immediately you must take up the patient for a cesarean section because you cannot lose any time. If you delay it for a few minutes, also the cord pulsations will disappear. That is, the blood supply to the fetus will be lost, will stop, and then the fetal death will occur. So, if you want to save the fetus here, immediate cesarean section must be done. So always when you do the pelvic examination, you rule out the cord prolapse. Now, if there is no cord prolapse, what you should do? See, most of the time, if you rule out other conditions like a multiple pregnancy or a say a contracted pelvis, then what you can do is simply leave the patient alone. There's no need to do much. As labor is progressing, more and more head is descending. It simply pushes the head, simply pushes the hand or foot up, and it gets corrected, and then normal labor will occur. Now, if after a few hours also, if labor has not progressed for any other reason, and still the hand or foot is still presenting, then you assess the condition, and here then you may have to do a cesarean section. But most of the time, 90% of the cases, it gets corrected and there's no need to do much. Okay, it's a small topic. So there ends my class today. Anything you want to ask me, you can ask since there is little time now. Yes, nobody wants to ask anything. I was audible, no, throughout the lecture?
Yes, ma'am, you were audible.
Okay, thank you. Any doubts? No? See, contraception is a very, very important topic. Every paper, I think in the second paper, in the gynec paper, you will get one or two questions on this contraception. So if you know that thoroughly, at least two questions you can answer in the theory. And not only that, in the practicals, also in the orals, marks are allotted. We ask only on contraception. So marks are specially allotted for this contraception. So I hope you all have paid some attention and understood. Please do read up since you're all at home only now. You can read up and catch up on all the topics that I have taught you.